Clinical Genomist with Roche, Dr. Jayaprakash Madhavan, Senior Consultant, Clinical Oncology, King's Trivandrum, Dr. Jojo Joseph, Chief of Surgical Oncology, Caritas Hospital, Kottayam. Over to you, Dr. Krupashankar.
Thank you. Alright, well, good afternoon once again. So let me quickly kick things off again. So I think we don't have a medical oncologist on the panel, is that right? Alright, it's fine. That's alright. So we have geneticists, we have surgeons, we have radiation oncologists and a healthy mix of clinical oncologists as well. Perfect. So let's set the ball rolling. I think, we're going to look at the role of genomic testing. So moving away from just CGP alone, what about genomic testing? Why, what, where, when and how? But I think the key question that most of our patients will actually ask us is this: how much? So it's not just why, what, when, where and how, it's actually how much as well. And that's usually it. So I'm like, let's talk about early breast cancer, and probably if I can begin with the surgeons. How do you look at defining early breast cancer as far as T and end staging is concerned? We'll begin with Dr. Jojo. Glad you could join Dr. KMG, sir. So Dr. Jojo, maybe we could begin with you, sir. How do you look at defining early breast cancer? I mean, just for all of us to take home and understand. Up to what T stage and end stage?
So, we include men generally on the T stage.
That's right.
Nodal status is not included in the early breast cancer. So T1, obviously T1 and
yes, I think it's up to T2 and N1. Anything up to T2 and N1 is early breast cancer. Any T3 or N2 makes it locally advanced breast cancer. T3 N0 and T3 11, or in the surgeon's language called as operable LABC. So I think that's sort of current terminology that all of us, most of us will agree with, right? So early breast cancer, let's talk about deciding on adjuvant therapy. How many of us actually end up using these online tools, or as I would call it, the clinical decision support system or a clinician decision support system? We'll begin this slide from Ganga itself. So I'm like,
usually my policy is always for the detailed pathology reports, patient assessment, patient factors. Then we'll detail assessment of each and every factors with the pathologist, we'll discuss pathology again. And age of the factor and other parameters of comorbidity. Then we'll decide what to choose. Usually I don't, very rarely have to go for an online tool, because my brain is always confined to what is pathology report, ERPR, status, rarely listen for oncotype. That is I can.
So let's say, yes,
yeah, I found our medical oncologists quite often use the EndoPredict as a tool to just find out the risk stratification. Oncotype DX, of course, in a very handful of patients who can afford it, but otherwise, generally, it is, we have our own technique of looking at the fall in KI67 with the neoadjuvant hormone therapy as a tool which we use sometimes, but that's the personal understanding.
Correct, absolutely. I think we're going to get to that. I'll talk about the poor man's Oncotype DX as well, which probably would be the KI67. But in practice, I think most of us, we tend to have some sort of tool to actually help us or aid in our decision making. Just to have a support, say probably you have a 2 to 3% benefit.
But remember discussion we put in occasionally put, because borderline area we put in an open meeting for benefit of pattern.
That's right. So most of us tend to do it. But I think the key drawbacks with this sort of online tools, be it the adjuvant online as well, which remains offline most of the time. So should be probably called adjuvant offline. So, but nevertheless, these are all based only on retrospective data. There is no prospective randomized phase 3 evidence for any of these tools. But when a patient can't afford to get any genomic testing done, and probably something is better, probably we go inside here as well. Sir, in your practice as well, have you ever you had to use? Yeah. Uni, you like this as well? Yes. Perfect. I would too. Just as an aid. I mean, like you could probably tell your patient, right? You probably have a 2 to 3% extra benefit if you can use it. Right? Perfect. So I think that's probably our opinion, because our patients would say, take chemotherapy, it's good for you. Right. So again, let me again put another scenario here. Probably I'll bring in Simbu here. Simbu, I know probably it's not your domain, but I would still begin with you. 0.5 centimeters, grade 3. Okay, tumor. Would you offer genomic testing to this patient?
So earlier, if the pathology is well defined already, whatever the histological things need to be.
Okay, let me put it this way: pre-menopausal, IDC, grade 3. Okay. and 0.5 centimeters.
So
Patients want to know if they will benefit from adjuvant chemotherapy. So would you offer genomic testing to them? Yes, no?
Yes.
Or just a quick show of hands. Everybody, does everybody on the panel agree?
Yes.
That you would offer for a 0.5 centimeter lesion if it's grade 3? Okay. Everyone, it's a unanimous yes?
No, I don't.
Okay.
I don't agree.
Govind sir, Muni? No. Okay. Okay, let me put it this way then. Okay. What cutoff do you use in practice then? I mean, like T1C or beyond, or more than 0.5 centimeters? How do we do? And does the grade matter? What is the inclusion criteria for TaylorX data? I think that's what we're looking at here. So I think anything more than 1 centimeter, definitely yes, you've got to offer it for all comers. More than 0.5 centimeters, between 0.6 to 1 centimeter, it's only for grade 2 and grade 3. And 0.5 or less than that, irrespective of the grade, you can't offer genomic testing. So I think that's probably the take home that I wanted to stress on as well. So it can't be for all comers. First we should probably look at identifying whom we should offer this genomic testing to in practice. So I think again we have a host of all these tests, right? Oncotype DX, MammaPrint, EndoPredict, PAM50, Prosigna, all of these, right? BCI, Breast Cancer Index. Then you have your Indian Can Assist as well. Is there a preference in practice? I'll probably bring in Dr. Jayaprakash. In your practice, what you would prefer doing oncotypes. If the patient can't afford oncotype DX, is there an alternative which you would? MammaPrint. Okay. Anyone else? Yes, sir. Yes, sir.
I have tried Can Assist in a number of patients, but again, as I said, the data is not strong enough to be able to reliably say yes. And I don't think it's safe all the time. But Can Assist I have used in quite a few patients because of its affordability factor. But again, because it is IHC based, how much is the translational actual this thing goes? Again, they don't have a prospective study. It's all based on parent block samples afterwards and this thing.
When you look into all these things, you can see only Oncotype has got a prospective validation.
Even
MammaPrint
as well. So
there are a lot of other factors.
Fair enough. Go ahead, sir, if you wanted to.
Talking about NS, just to point out, they have a validation.
Correct. We're going to show that as well. So yeah, we're going to get there eventually. That will probably be best for us, especially Indian data, Indian patients, because none of these tests included Indian patients. And I'll show you the ICMR guidelines as well. You'll be shocked to see that none of these Western tests are actually recommended by the Indian guidelines as well. So I think this is what it stands. This was the earlier TaylorX data. You could avoid chemotherapy in 70% of your patients. Is that what you would tell in practice as well, sir, when you offer the testing?
But in discussion, I will put a Oncotype DX standard of things. I will always explain patient that this is our standard of things. This is available proper data. But we can, I will usually, very few patients are not willing for chemo, early breast cancer, not willing for chemo. Next option, I put this is Indian data is the Can Assist. If the validation is not adequate, we can, option I will give to few patients, especially in postmenopausal patients. They are not willing for chemo. They are reasonably, therefore, reasonable tumors. So by looking the parameters, few patients are choose.
So the reason why I probably brought this up was, we know it's an expensive test, close to 3 lakhs. So we do it, especially in premenopausal node negative, and you have a score between 15 to 25. Let's say 18, or let's say 21. What do you tell them? How do you concept? What do you tell them? I mean, I've done a test for 3 lakhs. I still do not know whether you may or may not benefit from chemotherapy. So how do you do that in practice? Again, Vijay sir,
No, so
you don't.
I tell them clearly that if you get a clear score, we may be able to tell you. But if not, my preference has always been to do ovarian suppression in the premenopausal age group.
Okay, we'll get to that as well. So I think that's where probably I talked about implementing the clinical risk score as well. It's not just using the genomic risk. We all thought that the genomic risk overrides the clinical risk. Well, that's not actually true. We're going to look at combining both. And even if you look at the RS clean or the recurrence score clinical, which was validated in patients from the TaylorX data, I'll show you that study as well. So they incorporated the clinical risk factors and they were better able to delineate these risk subgroups as well. So we spoke about MammaPrint as well, and there were a few takers for MammaPrint here who said they would do MammaPrint as their second option. So would you do it in all comers or selectively, in a clinically low risk, high risk? How do you look at using MammaPrint at all if you were to use it in practice? So for all comers?
If they are not going to Oncotype DX, then I will discuss the options of MammaPrint.
Okay. And again, the key take home should be that, I think the key take home should be that it should be done only in clinically high risk patients to avoid chemotherapy. So it can't be used in low risk patients to gauge their benefit from adjuvant chemotherapy. So I think that's the only thing. Again, the advantage is that you don't have an intermediate risk group as far as namaparade is concerned. So it's either low risk or high risk, but only in patients who have clinical high risk factors. Again, this is based on the data that I showed you earlier as far as Predict Plus and Adjuvant Online. So those are the same factors: the tumor size, nodal status, grade, key 67. All those factors are how we look at defining them as clinically high risk or not. And again, so this is how this was prospectively validated even in the 1 to 3 nodes. And node positive premenopausal, I think it's very clear. You have to give them chemotherapy. I think that's clear. That's it. We have no doubt about that question at all. So I think the key thing was here. This is what was alluded to earlier as well. They said, why not give OFS plus hormonal therapy? Would that be as good as giving chemotherapy again? So, do you agree with that statement? Let's say probably somebody who falls into that.
Now the data is chemo is again important, especially in high-risk patients.
It's important, but do you believe that it's more?
I don't believe that avoiding chemo in a high-risk patient. That's about me.
Okay, but do you believe that it's because of the chemo-induced amenorrhea or the chemo-induced ovarian function suppression that's actually bringing about the benefit? Why not do just OFS alone? Endocrine therapy, especially in that subgroup between 15 to 25. Would this be an alternative? Accessible?
We do use it as an alternative.
As an alternative. I think yes. So I'll share that data as well. So probably between 15 to thyroid, sir, glad you could join us. Alright. So between 15 to 20, I think probably is where that subgroup would actually probably look at doing even OFS plus endocrine therapy as an option. But beyond 20, because there your distant recurrence-free survival, there's a benefit of close to 6% with chemotherapy. I'll show you that data as we move along.
But many premenopausal patients do not agree for OFS.
Correct.
That's also the quality of life is very important.
Correct. So it depends on what type of OFS we are offering them as well. So we're not talking about just doing a laparoscopic BSL alone. You could probably offer them even your GNRH analogs. Again, plus or minus, if they can.
5 years treatment.
Correct. It is for 5 years. But again, that data has shown overall survival benefit as well. If you look at the 12-year or 13-year update from the soft and text data, again, younger patients do benefit from ovarian function suppression, especially age less than 35 years, node positive, high grade, grade 3, all of them, and people who want to receive adjuvant chemo. So I think that data is there. So I think should you follow the data or your instincts? I'll tell you this. This is how it looks like as far as if I were to put it in a nutshell. So in post-menopausal, it's very clear. Lymph node positive or negative, if you have a recurrence score less than 25, no chemotherapy, right? I think we would all agree on that. So the key debate here is on again, no debate in the premenopausal lymph node positive subgroup as well. Okay? They all benefit from, if node positive premenopausal, they all benefit from adjuvant chemo. So the debate starts with this lymph node negative and low and high clinical risk. And this is where incorporating the clinical risk factors also becomes important. Because look at the magnitude of benefit, especially if you have a recurrence score between 20 to 25, 6.4% versus 8.7%. So if you have a high clinical risk as well, so how do you look at defining high clinical risk, or how do you think on the trial, the TAILOR-X trial, they looked at defining high clinical risk? So I think this was an excellent editorial that came out. The precision of evidence needed to practice precision medicine. So actually, are we doing this? Because at the end of the day, you're doing such a personalized precision test and saying that, okay, fine, you may benefit, there might be a 6% benefit, 8% benefit. So I think that's probably most of our reactions. Yeah, please go ahead.
No, we generally tend to use the grade, the key 67 index as size of the tumor and the percentage positivity of the ERPR. If it is less positive. These are the things which we use as a clinical risk factors.
Agreed. I think that's what most of us would do in practice. But here, as far as this trial is concerned, because most of us talk about using the Oncotype DX in practice, so when we're doing that, we should stick to this clinical risk criteria which they have given us. So grade 1, more than 3 centimeters, grade 2 more than 2, or grade 3 more than 1 centimeters. That's how they have looked at defining clinical high risk as well. So if somebody falls into that grade zone between 15 to 20 and 21 to 25, and if they have high clinical risk factors, which could be either any of these, based on tumor size and grade alone, then you're justified in actually giving them adjuvant chemotherapy. So you have to incorporate the best of both worlds. It's not just doing a genomic testing as well, it's about incorporating your clinical and your genomic testing together. That would make it the best team ever. So again, we talked about Oncotype DX. So what about the poor man's Oncotype DX? Key 67, what should be the cutoff, and what about IHC4? We never talk about it, right? So probably simple if I could bring you in here. IHC4, is it gone? Is it like people have forgotten about it? Semi-quantitative measurement? So, or is it something that we only discuss in theory and
Sir, nowadays most of them are not using the IHC4 at all actually.
Okay.
Right? So it's very.
I'm not even aware of any labs that are currently doing an IHC4 analysis. Yeah,
the routine practice IHC4 is a part of our plan. Because that has got some additional benefit. Because one early breast cancer will think of, say, intraobservational variability is there. Each pathologist has a different opinion. But once you are one senior pathologist, expert in breast cancer, he comment that it is 30%, 40%, you can believe that. So I think we don't completely omit. And as I mentioned, as I am doing this as another tool because cost effective, simple thing, easily available. Our pathologists are expert now because they are doing last 20 years.
Correct. I think what most of us tend to do in practice is that we look at ERPR and then a key 67 alone. But that's not your IHC4 analysis. IHC4 is actually a semi-quantitative measurement based on a machine algorithm, which actually gives you a recurrence score. So that's not being done at all. We're just looking at doing a key 67 alone, and based on, and even in that the cutoffs are different. Clinical trials we used a cutoff of 14%, but in practice we do 20%. Raj sir, you have done IHC4 or you're just doing only key 67 for your patients if they can't afford genomic testing. And while you're at it, you can also tell us about whether you're doing CAN assist. I know you love CAN assist. So.
The problem with KI67 is there is standardization is very difficult, and different labs have different standardization. That's
we don't have a centralized lab reporting system.
That's the biggest problem. CAN assist is, we are doing it, and it's very useful. KI67 with the 3 markers we are putting it.
And is anyone aware of an online tool that can help us decide whether which patients actually need to get an oncotype DX done? Do we have an online tool for that? Okay. So there is something called the MAGI equation, MEGW, MAGI equation, which has been developed by the University of Pittsburgh, UPMC. And so they have looked at quantifying it by using a head score or the histological score. And I'll show you that algorithm as well. And they triage patients who would actually need further genomic testing as opposed to patients who are actually for molecular testing. So that's another way of actually triaging or selecting which patients will actually benefit.
Can I just add?
Sure, please.
We have published 2 studies recently. Both are looking at the fall in KI67 after use of 1 or 2 weeks of hormone therapy, neoadjuvant hormone for all. And we have shown that a fall of more than 80% is something which we could use as an indicator, because the objectivity of the subjectivity of the pathologist is same in both cases. I think you have one value before and one value after 2 weeks of hormone therapy.
Absolutely. So I completely agree with you on that. Even a lot of CDK4/6 inhibitors are also looking at using the same strategy as well, the Neopalanan study and all of them, especially this drop in KI67. If it's 20%, 40%, I mean, they look at quantifying it as far as responses are concerned, the drop in KI67. So I agree with you on that.
But there we use 10% as a cutoff, not this thing. Less than 10% is the one which is considered low key.
Okay. So yeah, the different trials have used different cutoffs. But I think again the problem here is that low ER positivity again. That's another thing that's been debated on. Because if you look at by definition, anybody more than 1% becomes ER positive. But we know there's a low positive subgroup, which is less than 10%, who don't derive as much benefit from endocrine therapy. So it's more than that 10% who actually benefit from endocrine therapy as well. So we know the algorithm score, the percentage as well as the state of the stain and also the intensity of the staining as well. So 2 parameters. So coming back.
We use the audit score less than 3 as negative, right?
Correct. So that's out of 8. But I'm talking about only the percentage of cells that stain of the staining. More than 1%, we say it's positive. So for that.
Always the score, not only the staining, but the percentage.
Correct. But for patients who actually benefit, I mean, there is a new entity, like how we are calling HER2 low and HER2 ultra low. Now we have ER low as well. And ER low means ER is positive but between 1 to 10%. So that's another subset that's actually coming in. It's called the ER low subset. Anyway, moving on to, I think this is the problem that we have in India. Most of them come with younger stage and higher nodal positivity, high tumor burden as well. And look at the ICMR guidelines. None of the Western tests are actually approved by our ICMR guidelines if you look at the Indian specific guidelines as well. So I think you're not wrong in actually offering your CAN assist. I mean, I think it's it's a very good test. Even I do it a lot in practice. So I think it's horses for courses. I mean, like how many Indian patients were included in the Taylor X or the RX Expounder or the Mind Act? No, zero patients from India. So I think it's not just about going to bed with our favorite NCCN guidelines or ESMA. I think we have to look at forming our own Indian guidelines or an NCG, National Cancer Guidelines. So this is the CAN assist, IHC based. But the good thing is it incorporates the clinical risk factors as well. The tumor size, nodal status and grade. Apart from your IHC based markers, which is your epithelial mesenchymal transcription markers like CD44 and ABC, which is your ATP binding cassette, ABCC4 and 11, which actually predict for resistance to chemotherapy, apart from your ecadherin and encadherin, which are for MET inhibition, which is basically mesenchymal epithelial transcription, or your reversal of the AMT, which promotes invasion and metastasis. So these are key markers which we understand, which can be important. So I think that we always ask, right? Is it FDA approved? No. But I think this is very valid data. I think this is what Dr. Govind sir is also trying to tell us. They have looked at comparing it, and you have an 80% concordance with Oncotype DX. So is this not good enough? Gangadharan sir, we'll begin with you, since you said only Oncotype DX for your patient. If your patient can't afford,
I always give second option. Canasis is there because
perfect.
Any patient comes with my OPD, I will always give there is one option is there. It is costing 5,000. Otherwise 3.2 lakhs. One option is chemo because there are also chemo is 20,000. It is a different thing. So
correct. That's a very practical approach, I think. Simbu, your thoughts as well? Would you agree that, okay, fine, this is a fairly acceptable alternative?